We're live.
We're live.
Welcome to the COVID-19 CommunityResources.com Town Hall meeting. Thank you for joining us. You know, it's powered by the Center for Closing the Health Gap, and we are so grateful to the Center for Closing the Health Gap and our tech team, John Reichel and Lauren Harden. And thank you everybody for joining us. You know, we've been talking a lot about COVID-19. We haven't talked so much about how COVID-19 affects substance abuse. And so today we're going to talk about that subject. We're going to talk about access to treatment, and we're going to talk to two folks from two great community organizations that provide treatment for substance abuse. So we've got a really good topic today. You know, if you're on Zoom or Facebook, you can start entering your questions now. We'll get to them in just a minute. Also, just a reminder, we are recording our session and we will post it later on our COVID-19 CommunityResources.com page. So everybody, welcome, sit back, relax, get ready for a really good conversation about COVID-19 and substance abuse. Let me introduce our panel. We have, and I'm not sure if she's on yet, there were a few tech issues with Leah Dennis-Ellsworth, Executive Director of the Urban Minority Alcoholism and Drug Abuse Outreach Programs, and you probably know it as UMADAOP. And people are like, what does that stand for? Now you know. Also, Jamahal Boyd, who's Executive Director of Crossroads Center, and as he likes to say, not the church, it's Crossroads Center. Healthcare Center. And then we have Dr. Randi Burlew, who's back with us, and she's a Senior Research Associate with the Philliber Research Associates. So let me ask all of you, first of all, thank you so much for joining us. We're so excited to talk with you today. And I should have said, I didn't introduce myself. I'm your moderator, Cincinnati City Councilmember Jan-Michele Kearney. Okay, let's have each of you just make some quick intro remarks, and then we're going to get to our Q&A because the questions already have started. So why don't we start with Jamahal Boyd.
Sure. Thanks. First, thank God for the opportunity to share today and be a part of this esteemed panel, and along with these esteemed honorees that are with us today. My name is Jamahal C. Boyd Sr. I am the CEO of the Crossroads Center. We provide mental, behavioral health, substance use disorder treatment services in the Cincinnati region and abroad. And we are pleased to be able to share with you what we do today and hopefully some context around what's going on relative to COVID. We have an intensive outpatient program as well as two residential programs within our facility, one that caters to women in our Cheney Island Women's Program, and the other is our adult residential care program, and we house up to 32 residents in both of those programs collectively. And as well, we also have a methadone treatment center where we treat in excess of about 500 clients a day for methadone care in our facility. But COVID has had an impact on that as well. But looking forward to sharing, and thank you for having me today.
Thank you so much. Okay, Dr. Randi Burlew, she's back with us today, and we're so happy to see you.
Thank you. Thank you so much for having me back again. And I'm hoping that I can share a little bit about substance abuse in the broader mental health context for the Black community, and particularly in the age of coronavirus. And as you know, there's been a lot of discussion about the impact of coronavirus on our physical health, and we know that hospitalizations and mortality rates are higher in our community. But it's also important that we're aware that due to systemic inequities, historical traumas, disenfranchisement from the mental health system, and higher existing rates of some mental health symptoms, that we also have some mental health vulnerabilities in the Black community. And also that it's important as a community that we work to maintain and protect our mental health and our sobriety. So as we think about strategies to address substance abuse and mental health in the Black community in the age of coronavirus, we also want to be thinking about making sure we're tailoring our strategies to the particular needs of our community. And what that means is we need to address barriers in the Black community to seeking substance abuse and mental health care, such as cost, stigma, cultural insensitivity in the mental health and substance abuse field. We need to acknowledge that some members of our community have a reasonable distrust of providers due to historical mistreatment in the medical field. We need to ensure that there are culturally appropriate mental health treatments. And so I'm so glad to be here with my fellow panelists who can really speak to this, because we already know that treatments that are not culturally tailored have higher dropout rates. And finally, we need to really advocate for comprehensive government funding for integrated behavioral health care so that there's access in our community to mental health and substance abuse treatment.
So, Dr. Burlew, thank you for those points. You've made a lot of good points. And so once we get started, it would be great to go through each one and kind of, flesh those out, because those are all great topics. Now, Leah Dennis-Ellsworth is calling in. I'm not sure, Leah, are you on the line yet? I see that she had a few tech issues. Okay, well, let's do this. Dr. Burlew, let me start with you, because here's one question, and it says, what is the research telling us is the impact of coronavirus on the mental health of the Black community?
Well, we're really starting to see some really interesting research that's letting us get some insight into this. So, for example, the Census Bureau has an ongoing survey where they're looking to determine how prevalent things like anxiety and depression are. And what the data is telling us is that between January and June of this year, so the period where we've been really dealing with the coronavirus, the percentage of Black people screening positive for anxiety has increased from 8% to about 34%.
Wow.
When we look at,
yeah,
it's a huge jump. And when we look at depression, we see a similar increase from about 8% to 30%. And while there's been an increase in depression and anxiety rates for the white community as well, that increase has not been as large as the increase in the Black community. We also have to keep in mind that the Black community is not just dealing with the stress of coronavirus. We're also dealing with the impact of ongoing racism. And so if we look at the data from that same survey, we also see that there was an increase in rates of depression and anxiety in the Black community right in that week when the footage of the killing of George Floyd got released to the public. And what we saw was that the percentage of Black Americans screening positive for anxiety and depression spiked in that week, which in a manner that translated into about 1.4 million more members of our community screening positive for either depression or anxiety. So we've really got two battles going on that impact both our mental health more generally, but also could be triggers for substance abuse as well.
Oh my goodness, that's that 8% to 33% just really like knocked me over. That's just such a huge difference. Okay, thank you for that question. And Jamal, let me ask you, because let's talk about COVID and substance abuse. What's that relationship?
It's a direct relationship from what we've seen since March. A lot of our clients, we deal with the most complex issues because we have the issues that clients and patients bring from a chronic disease perspective, as well as from a substance use disorder or mental health disorder perspective. So when they come to our centers, we are dealing with the most complex issues that are compounded by not just COVID, but the cultural challenges, as well as the social determinants issues that they bring forth when we treat them. So it's not just COVID, it's compounded with a number of issues that our facility has to deal with. And it is something that, in my conversations with a lot of other health systems and providers, it's a community effort to deal with all of what we have to deal with, because it always expands beyond what we're capable of doing within our four walls. But to answer the question, COVID has compounded that tremendously because folks are out of work, they're home at times when they're not normally home, having to deal with issues that they've not had to deal with. And, the other challenge that we face is not just getting African Americans and others into care, it's keeping them there. And the challenges of COVID have compounded that as well. So, when we talk about the true impact of COVID, thank you, Dr. Burlew, for the data that was shared, but I believe even more data is out there that we're not even aware of, that we're not capturing, because that's only the folks who are coming in that we know about. that's not dealing with the audience of individuals out there that my outreach team and others are trying to bring in and have them get access to care, which is one of our points of today. Because people, one, either they don't know, two, afraid because of all of the reasons Dr. Burlew mentioned earlier to come in for care. And then when they get there, they're dealing with so much around housing, transportation, childcare, domestic issues at home, food insecurity, you name it. These social determinants are what are either drawing them out from receiving the services or back out into the environment that they came from because they're more concerned that those things are more important than their sobriety.
Well, so, and you talked about that whole outreach effort, how does that work? I mean, some people, as you said, will just come in, but then there are all those folks out there who aren't going to come in just voluntarily. They're not going to just walk in the door. What is that outreach effort like?
Well, it's multi-faceted when you look at what outreach truly is. When somebody's in need, a pamphlet's not going to meet their need, and for some people that works, for some people it doesn't. But we at the Crossroads Center have really tried to be as innovative as possible in our outreach efforts in terms of getting into the streets, touching people, and making sure that that touch converts into service or care or treatment, and tracking that to measure it and say, what is the outcome of it? And it's not just, again, passing out a brochure about our programs and services that we offer, but engaging them with counselors and ensuring that folks have a live person or body to talk to, understanding what is available to them and getting them connected to those things. Those are all very intentional outreach efforts, because when I joined the Crossroads Center a year ago, we weren't doing it to that magnitude. It was more or less attending events, setting up a booth, and expecting people to come into our four walls. But then when you look at the numbers that Dr. Burlew expressed, the numbers in the African-American community, I think our percentage of treatment is around 4% or 5% relative to the census that's out there. And we know for a fact that if you look at the criminal justice system records and other things, that other data that's out there, there are more African Americans that are impacted by substance abuse than those who are coming through our door. So our approach was always get out there, get in the street, touch people. Partnerships are also another part of that, Jan, because what we do is we work with, and I've been having conversations with the CEO at Cincinnati Metropolitan Housing Authority, the Criminal Justice Center, working in the community to say, how can we touch more people to make them aware and give them access to what we do so that we can impact the disease in a different type of way.
And Eric Kearney is asking, what can we do to help you with your work? And, I think that's a great follow-up question, because it sounds like you need like a whole army of people out there. I mean, you can't just have your staff, and I see that you're partnering with other organizations, but who else can help? I mean, it seems like churches can help you.
Absolutely. So I have been on a meeting campaign. I really have, and when I looked at the numbers of meetings that I've had, I think I've had over 150 meetings with individuals. CPD, I met with Chief Isaac, I met with Chief Tom Sinan from Newtown, and other police and the public service agencies to figure out, how do we serve as a stopgap? How do we serve as an institution or an organization that really deals with what we do well, but in partnership with others that touch the people that are coming to us? Hospitals and health systems can help. Other nonprofit agencies. Leah, who is supposed to be with us today, is a part of a group of providers from the Cincinnati region, where for me, it's not competition. It's about making sure that no matter who you are, where you are, what you are, we get you access to what you need. And it's not about trying to get, the number one agency or, the people who are seeing the most people. It's not about that for me. It's really about healing the ill that's in the community. So, and funding is a big part of it as well, because we cannot do this. Most nonprofits are begging and borrowing every dime just to stay afloat. And when you talk about the impact of COVID, it's impacted every one of our budget. But, being able to fund some of these outreach efforts, being able to fund some of these stopgap initiatives that deal with the social determinants piece, being able to provide housing vouchers and transportation vouchers and things like that. Most of our agencies don't have a budget to absorb these things, but funding, partnerships, and being able to close the gap with measurable and sustainable approaches, because I don't think that, just doing stuff to check boxes isn't enough. It's not going to help deal with what's really happening. We need to put plans in place, and it's a heavy lift, but not many organizations want to do the work, unfortunately.
Okay. So, so the good news also is that Leah Dennis-Ellsworth has been able to log in. Leah, are you there? Can you hear us?
I am. Can you hear me, Jan?
Yes, we can all hear you. Welcome. We're sorry about
Oh,
your video.
wow. Thank you so much. Thank you so much. When you're an old guard, you're not still familiar with all this technology. And in fact, I'm so happy that I'm able to hear you guys and to become live so people can share some of the information. I heard you, Jamahal, and I really appreciate all the things that you said. We're going to ditto that. But in fact, I like to say that UMADAOP of Cincinnati is unique in that we target specifically Black and Brown Americans. And so in saying that, we were able to receive source funding from the state of Ohio to address those same issues that you talked about. So I was fortunate for the last 9 months of my tenure to receive at least $1.5 million in trying to launch a city outreach campaign to do those things that you talked about. And this is one of the avenues that we can use. I have actually partnered with a lot of the churches, community councils, leaders, stakeholders, and other service providers, and individuals who just want to help in the business field to be able to get that reach and to show that, in fact, not only are we dealing with the pandemic crisis, we're dealing with an opioid crisis that is affecting our Black and Brown communities. And that's where we are in terms of our mission at UMADAOP of Cincinnati. And so we're fortunate to have 12 of us in the state of Ohio that is addressing that issue right now. And so I'm happy to say that, UMADAOP, as small as we are, we're mighty in our scope and evidence-based practices to culturally, specifically address and practice the avocation of healing the wholeness of the client while promoting healthy families and stronger communities. That's where we are.
All right, that's a strong statement. So let me ask you a few questions about some points you said. So when you're doing this outreach to the churches, for example, what is your ask? What are you asking them to do?
Well, of course, like Jamal pointed out, there are measurables. And so in our grant, we had goals and objectives that we asked our stakeholders, our churches to do. They are to provide, ensure that at least 250 people are being served by being able to contact, talk to them about the crisis, talk to them about where to go, talk to them about the access of treatment, all forms of treatment. That includes medication-assisted treatment, those individuals who are struggling, who may have difficulty because of the shutdown and the shelter in place. A lot of our clients are afraid to go and come back to treatment. They're feeling alone. They're depressed, which is the reason why we have an uptick in our opioid epidemic right now in the Black and Brown communities and population. And so with this money, they're able to go out in the community in a different format that is more of a virtual piece, more of what you see is these pop-up distribution, grocery and food setups where they go and talk to the community. We have also virtual and webinars. We're doing training. We do have Creating Lasting Families, which is a program that we utilize that is state recognized to help the whole family, which means we're talking about not only treatment with medication. If you're having a relapse or you're in recovery, some of our individuals need medication to help with that. So we provide that along with psychotherapy, cognitive behavior therapy, prevention education in the school systems with the families to make sure that we are looking at the broad spectrum of healing.
Okay. And so, and you really started talking about my second question, because you talked about looking at the whole person and looking at the family. What is the effect of all this on the family? You know, how do you help with family members?
We were, prior to the pandemic, we were serving over 240 students in the school system, because we have a wonderful prevention team that goes out, and we are school-based, and we do what is called social skills and resistance and life skills that are set up to talk to students about how to resist peer pressure, decision-making, which is some of the same things that cause our young people to want to use drugs as a result of the impact of maybe having family members or even their parents incarcerated, or parents who are on the drug, and then how that impacts them. We call that high-risk families. And so that impacts them. And so we try to, on the front side, prevent that.
And we do have that. We have funding.
Peer pressure or something else. I'm sorry, Jamal.
Yes.
Go ahead.
No, I was just saying, we also have initiatives around the high-risk families to try and build the support system and the awareness and the education and resources of those who are connected to the individual that is addicted. So we've been working alongside what is happening at UMADAOP through funding that we received from the Hamilton County Mental Health Recovery Services Board to do those types of interventions. And I just wanted to also just double back on what you had asked about the church and the approach that we've been doing with them. We've taken that a step further. Prior to COVID, we were looking at how through large churches, small churches, and the congregation setting, we provide intervention and service there. Because one of the things that a number of the pastors that we had been working with, that I had spoken with, were saying is they get to a point where they stop and they can only provide a level of spiritual guidance, counseling, or service. But then there's that mental health, behavioral health, or addiction treatment service piece that is outside of their scope. So we were looking at how can we develop a model that works within the church, a trusted entity as it stands, to be able to provide the extension of what the church doesn't do. And whether that was either on site or in partnership or virtual, we were in the process of developing that. One particular church was with Crossroads, the church, because of the name ambiguity. So we were looking at really how do we partner with them to develop a brand, because we're not the church, but we do the work of the church when you really think about it, and be able to make sure that we're leveraging that relationship to deal with the whole person, mind, body, and spirit. And in that, you address all of those concerns, as well as the social concerns that are in the community that impact their congregation as well.
Yeah,
and if I could just add from a research perspective, I think it's so important to highlight how amazing it is that these two particular organizations are on your panel today, because what we know in the research is that we've got to have interventions that really meet the needs of the Black community. And so as Leah said, UMADAOP is focused on these issues in Black and Brown communities. And just because I have worked with and know very well many of the therapists at the Crossroads Center, know that they also, many of them have an expertise in culturally appropriate treatment. This is so important for several of the reasons that Leah and Jamal have both raised, with regards to the fact that, you know, when we look at the work that Leah talked about doing in schools, we know that helping youth develop a positive cultural identity is a protective factor for substance abuse and many other risk behaviors. So to support an organization like Leah's, who is doing this work through a cultural lens, is very important. And sort of piggybacking on what Jamal said, you know, working with an organization that is committed to working with trusted leaders in the community is also very important, because we know there's a lot of stigma around getting some of this treatment, and being able to partner with organizations that already have those relationships in the community, like the church, and who already have that element of trust, really makes it easier to get people into treatment because you're working with organizations that they already trust.
And let me also make it very clear about the focus and refocus of the Crossroads Center since I've been there as their CEO. We care and treat every individual that comes through our doors or that is in need of service. But we are laser focused and particularly aligning our niche focus around focusing on the African American, the underserved, the underrepresented population that is out there that is not coming into our facility. So when we talked earlier about our outreach efforts, that is specifically targeted towards the African American community, specifically targeted towards the marginalized and those who are underrepresented and underserved. So I want to make sure that, you know, I know that UMADAOP does that with specific intention. So do we. You know, that is one of the things that I think in the Cincinnati region has not been a particularly marketed focus by agencies because of the challenges, the stereotypes, and all of what comes along with saying we're going to focus on this community. And we've taken that stance as the Crossroads Center to ensure that everyone knows that this is our focus and this is where we're going to, you know, hang our hat, if you will, while we care for the larger, broader community.
Okay. And I appreciate that. Of course, we would not turn anyone away from our doors, but we try to be specific about our focus. We are legislated by the state of Ohio. Actually, some of our Black history is that UMADAOP was legislated by the state Representative William Mallory Sr., who was responsible for this legislation that created 12 of the UMADAOPs as a result of the need to address, you know, African Americans and Hispanics and minorities because they were not being, again, like we see now, represented. So we take pride in the fact that that is our targeted population. But that doesn't mean that, of course, we do not accept others who will walk through our doors, because we do, because, you know, we help everyone. But
yeah, we understand that. Oh, I'm sorry. Go ahead, Leah.
But to piggyback on the fact that Crossroads is working with their Crossroads, we have had previously, maybe 3 years ago, UMADAOP developed a kit, a faith-based kit with Prevention First. Prevention First is the only prevention-type organization that does the policy making driven by data to determine the kind of prevention that's needed in specific regions. And the first church to do that, actually, and I like to say that is I'm a member of, is New Jerusalem Baptist Church. And Reverend Lynch was instrumental in developing that kit. They are also one of our flagship churches that are working along with us, as well as New Prospect, in trying to sound the alarm for the need for our African American and Hispanics to understand the crisis that we are facing due to the abuse of opioids. So they are on board, and we do have also Prevention First as one of our partners who are helping the churches as part of a grant that I wrote. The objective is to ensure that we can receive and develop more individuals that are coming from the church that want to be trained to be prevention providers. Okay. So we're looking down the road how this should look in terms of the future, because right now we do not have a lot of African Americans being trained to be Prevention First providers.
Okay, and Leah, we can talk more about that too. But let me, I want to get to a question. Nina Lewis is asking, can you identify some signs that might help family members know when a loved one needs substance use intervention or treatment?
Oh, absolutely. So what is happening now in terms of the drug use? We are having individuals to come in, and I'm sure Jamal would see this. Some of the signs are, again, the shakiness and the need to constantly wanting to go out, looking for someone when they can't even seem to, they're afraid to first go out, but they want to find someone to help them with the fact that they are feeling the addiction of the craving. The craving makes them shake. The craving causes them not to want to eat. They're constantly, because the fentanyl is a synthetic drug, and it's no different than the other opioids. So you would see people usually who are recreational users, as well as those who are using painkillers as a result of maybe an injury. Those individuals begin to want to find those type of drugs, which is, the ones that you would get from your doctor. So most of the opioid epidemic is the result of prescribed narcotics that are, your Vicodin, your oxycodone, your oxycodone, your methadone, and even your morphine. And so in wanting to constantly get that particular drug for whatever pain you're having, you start to become addicted, just like anything else, and start to have the shakes or starting to steal, starting to do kind of things that your family, that's unusual to do. And then they begin to look at something that is out in the street that helps to increase that high, and that is that fentanyl that is being laced in your cocaine, it's being laced in the heroin, it's being laced in the meth, and then what it does is it really is the fentanyl is the killer, because what it does is slows down the breathing and stops, and then you die. So because we're in this pandemic, a lot of our family members are not able to even connect to their other family members that may need the help because of the shelter in place, being afraid to be exposed. Right. And as well as
let me pivot over to Dr. Burlew, and you did a great job answering that question about what family members should look for, and so and also about starting with prescribed drugs, because that's a whole nother issue, and that's pretty scary. But I just want to pivot over to Dr. Burlew, because Leah, you started talking about COVID-19 and the impact. Dr. Burlew, can you tell us a little bit more about some of the data, like what's COVID-19's impact in the Black community in terms of substance abuse?
Well, I think similar to what Leah was talking about, we're seeing an uptick in the number of people who are using substances as their main or sole means of coping. In our community, what we know is that being able to connect socially is a really strong protective factor. And many people are disconnected from, their loved ones who are a source of strength. And so we're seeing that as a stress, as Leah mentioned. I think the other thing is that many of the coping strategies that people have been using to maintain their sobriety have been taken away. Shelter-in-place orders. Treatment that they might have been able to get in person is now not available in person in many cases, and people are having to look for other forms of treatment. Many providers are now providing substance abuse treatment via telehealth ways, and there are meetings that are available in non-face-to-face formats as well. So we're seeing, an increase in the stress that people are dealing with, so an increase in the triggers that people are being exposed to, and at the same time, we're seeing a change in their access to the strategies that they were using to maintain their sobriety. And so all of that leads to more difficulty maintaining sobriety and an uptick in what we're seeing in terms of substance use and substance misuse in the community.
Yeah, and Jamal, you touched on this too, about how during the pandemic, which is still going on and apparently isn't getting much better, how people were afraid to actually come to treatment, and they were and that's what Dr. Burlew was talking about too. Like, they need treatment, but you've been told to stay at home. I don't know if that teletreatment works as well. What do you think?
Yeah, so telehealth and teletherapy treatment has, as we've been looking at the data, been effective. And that's not just anecdotal, really in terms of the usage, the volume of usage, the actual treatment time that is allotted towards some of the care that's being provided telephonically or through one of the telehealth provisions. It's shown to be effective over the last few months. We did see a decline in in May, and we still have not identified what the decline in May was, but March, April, and July to date have ramped up in terms of telehealth service provision as we've been tracking it. And what that's also given us the opportunity to do was to advocate with the state for continuing to pay for these services, in which prior to COVID, they were not. But we've been advocating for Medicaid and other providers to continue to pay for it beyond the emergency rule and beyond the end of the COVID crisis, because one of the things that we strongly emphasize is that telehealth, teletherapy is not a replacement for care, because we still know research and data says that interaction with your therapist and counselor in person is better than being received over the phone. So we don't want that to be a replacement, but a supplement and a complement to care, and an access point that allows us to treat our patients and clients more effectively, because of the fact that a stay-at-home order says you can't come in, you can't go out unless it's essential. Although this is an essential service, we still have to do the social distancing and all of those things that we have to do to keep a safe and healthy environment. But telehealth has allowed us to extend our level of care that we provide to the community, and it has been to date proven effective.
Well, that, so telehealth is something that's necessary, but it's
absolutely. Yeah. It's another tool in the toolkit, and to remove it or to reduce it would be asinine on behalf of the payers and the providers in the state to say, now that COVID is over, let's go back to the way that things were. That would not be appropriate or smart at all at this point.
Right, and that brings up a question. This person is anonymous, which is fine. I was going to say, if you all want to leave your names, we love calling out who's asking the question, but being anonymous is fine too. So this person said, doesn't the COVID-19 pandemic provide the strongest argument for universal health care and Medicaid for all? So that gets back to what you're saying.
Well, I don't want to get into the political discussion about, the provision of insurance and insurance coverage. But what I will say to that from a, healthcare executive and leadership perspective is that there should be insurability or insurance for all people, and access to that is a right, and I think that in whatever form that comes, it's essential. No one should have to worry about when they have a health need or concern, how that gets paid or covered, or should have to bear the burden 100% out of their pocket. I mean, even as an executive, we have a plan, you have a deductible, and it's or co-insurance, and it's like, wow, if that was taken care of, or if I have to make the decision between feeding my family versus getting this procedure done, what do you think I'm going to do? So we should not, in whatever form or structure of insuring our population, place that burden on them to have to make that decision between healthcare versus life.
Right.
So I'll just
say, just to piggyback off of that, the discussions that have been had amongst certain people advocating for reducing healthcare healthcare access and insurance while we're in the middle of a global pandemic is really just unconscionable. We know that the needs are greater in our community, but in all communities, and people are suffering. So there are different, ideas politically about how we should ensure that everyone has the coverage that they need. And that's a discussion that can be had. But the thought that we would be reducing healthcare coverage or healthcare access in any way, shape, or form during the middle of a global health pandemic is absolutely
unconscionable. Absolutely.
Well, and I think the other piece to it is, before you can answer that question, you have to understand too what Dr. Burlew was getting at is the layers of impact disproportionately on communities of color. And when we don't look at it from that perspective, that's where challenges arise, because when decisions are being made by people that aren't impacted by that decision, of course, it's going to be that we move in a direction that does not support those who are disproportionately impacted, if that makes sense. And that's my challenge. Again, that's why I'm very reluctant to answer that question directly, because I may not be liked, and I don't care about being liked, to be quite honest. But, when we get to the meat of it, we really need to peel back the layers and to, as Dr. Burlew said, I'm very passionate about that piece, because again, when you're not from that community and it doesn't impact you that way, it is almost impossible for you to make a wise choice, especially when you're not looking at it from an inclusive lens. So, again, I'll stop there.
Yeah, I got you. Absolutely. So let me ask you this, because I want to get back to Dr. Burlew. You brought it up, and Jamal and Leah, you both touched on it. But the whole issue of racism and COVID-19 and substance abuse, and you've talked about how there's certain the treatment has to be tailored to the culture of the person. So how does all that come into play? Because I think people might say, isn't treatment? Like, why is that important? You even talked about, Dr. Burlew, you talked about self-awareness. And so, just kind of, bring that all home for us.
Well, yeah, from, I think, a global context, we have to understand that the field of mental health has really been developed on ideas that normalize the white experience. And so for any sort of mental health or substance abuse treatment or framework, we can't assume that just because something has worked in one community, that it's going to work in another community. We're all dealing with different challenges. And, part of why it's so important to take a health equity, a culturally tailored approach to this, is really thinking about why particular problems remain challenges and disproportionately challenges in some communities and not others. What we know from the research literature is that there are treatments that have been effective in the white community and have been tried in the Black community and have not worked. What we know is that racism, which is something that impacts you if you are a Black, Indigenous person of color, is a trauma and has its own mental health impacts. And if we're looking at trauma just from a global perspective that is informed really by an experience that normalizes whiteness, that doesn't really give you a frame of reference for the impact of racism on someone's mental health. We also know that there is a lot of structural racism in our community and all communities in this country, and it's having an impact. It impacts our access to care, it impacts the type of care that we get. We know from the research alone that for Black people, our mental health treatment, more often than white people, happens behind bars. We know that a lot of time our mental health symptoms, instead of being addressed by treatment, lead to things like arrest and incarceration, which is a trauma in and of itself. So we really need to look in our community and look at what do these mental health challenges look like for us, what's driving these mental health challenges, and what kinds of treatment is going to work for us. And we also know that there have been treatments in the past that have been damaging to our community. There's been research in the past that has been damaging in our community. And so, as I said earlier, for many people, there is a reasonable distrust of the medical profession. And we have to take a step back and say that when people are mistrustful, there are reasons for that mistrust. And one of the first steps we have to make is to assure people that we are coming from a place of equity, that we are coming from a place that respects their experiences, and that understands that your cultural and ethnic identity is a part of your whole self, and you need to be able to bring your whole self into treatment.
Right.
What I'll share on that is a number of approaches that, being in the healthcare industry since 1995, I've learned and watched and helped, some of which to develop relative to these specific issues. PBS did a series a number of years ago called Unnatural Causes that really got into the meat of looking at what the design of a healthcare system is, but in the delivery of health services, doing it in a way that tailors its services to measurable outcomes in disparate or disadvantaged communities. And it looked at a number of different things that were effective. We're talking over 10 years ago, and we're still talking about some of these same challenges today. Have we gotten it right? No. And we have such a significant opportunity to do so as we, particularly in my agency, we're focusing on how do we do that? You know, we have a broad scheme of how we deliver care and services, but how are the interventions different for a Latino, for an African American, for an Asian? Because you have to look at some of those cultural, racial, ethnic, socioeconomic components that trigger either trauma, stress, or their inability to follow through a treatment plan. It's all different, but how you deliver it to get different outcomes or get people to the same equitable outcomes, that's where those targeted interventions go in. Another very simplistic example of what we're talking about here, the American Heart Association did this a number of years ago as well, where they looked at healthy heart outcomes for people who struggle with heart disease. And what did they do? They created a healthy heart cookbook because they knew that cooking was a part of what leads to heart disease, particularly in the African American community, and said, here, African American population, we're talking about heart disease and how to get everybody's numbers to a certain level, but here's a cookbook because we know culturally you like to eat A, B, and C. But if you eat those things and that is something you can't get away from, here's a healthy way to cook it. And they did that in a number of cultural ways that were effective. What did they see? They saw results in heart disease in the African American community decline as a result of distributing this culturally driven, appropriate resource in that targeted community. So can it work? Yes, we just have to have the willingness to do it, Jan.
Yeah, and I just want to say, like, one of the things that I think that highlights is historically when we have looked at inequities in our community, we've asked the wrong questions. The question becomes, what is wrong with Black people as opposed to what is wrong with policies and institutions?
Yes.
So we have to take a step back when we're addressing these challenges and not come from a lens that says that there's something wrong with our community, but that recognizes that there are policies and institutions that are set up to perpetuate these inequities.
You know, I'm so glad you said that, because I think that's a frustration that, you know, that I experience. I think so many of us experience. I feel like we're out there trying to prove that there is systemic racism because a lot of people just don't get it. They're like, what are you talking about? Like, everything's fine. You know, we're all colorblind. I mean, you know, it's not. There are systems in place. I mean, these things are really no accident. And so, you know, there is like that fear that we'll just look at ourselves and say, you know, what's wrong with us? Why do we have all this, you know, obesity and diabetes and, you know, high blood pressure? You know, what's wrong with us? And it's, you know, I love the way you said that. It's the policies, it's the institutions in place. So, and you know, the health gap, this is the work they've been doing. And I think, you know, with COVID-19, people suddenly took a second look and said, wait a minute, they've been talking about this for years. Maybe they're right. Maybe there are health disparities. It's like, you know, we've been trying to say that. So, you know, the fact that treatment has to be culturally based is something that I know you all are really, you know, working with and trying to get people to understand. So it's so important. You know, and let me ask you, you know, just speaking of COVID, you know, and Dr. Burlew, I'm going to start with you with this question, but what can we learn from past crises? Like, we've had Hurricane Katrina, we've had, you know, HIV, we've had Ebola. What's the long-term impact on the Black community? We're still going through this pandemic. We know we're going to get through it, but then what's, you know, what can we expect? What do we need to really look out for?
I think we can learn a lot from these past things like Ebola and Hurricane Katrina. One is that there are likely to be significant and persistent mental health and substance abuse treatment. So even when we've gotten through coronavirus, the impact of it on our community and on our mental health will still be happening. It's not going to end right away. So there'll likely be increases ongoing in things like anxiety, depression, substance abuse, and post-traumatic stress disorder. We're already seeing those increases. And so we have every reason, based on what we've seen from some of these other crises, to think that that's going to extend even after we feel like we're over coronavirus. And I think the other thing is when we look specifically at Hurricane Katrina and the Black community, what we know is that the strongest predictor of negative mental health outcomes was loss of life, losing someone close to you. And what we know about coronavirus is that at this point in the pandemic, about 1/3 of Black people have already lost a friend or family member. And so that grief and that loss is going to be with us for a while, and we have to be ready for that.
Yes.
I think we can also expect that as we're recovering, much like other recoveries, the Black community is likely to be left out in some very important ways of the recovery. So as we are putting together these different HEROES acts and other acts, we really need to make sure that our community is not being left behind.
Okay,
Absolutely.
thank you. And Leah, I can hear you jumping in. Go right ahead.
Oh yeah, absolutely. And that's my rant. You know, I am part of the Hamilton County Addiction Response Coalition with Niehaus, Denise, and one of my rants there, being one of the few African Americans, is about just that. You know, we need to be represented in all of those areas to make sure, you know, our voice is being heard, specifically for the Black and brown vulnerable individuals in our communities. That is really the problem that we have. If we are not there at the policy, and thank you so much, Jan-Michele, we see and we hear you every day, seeing what you're doing, because the policies got to be changed at the level, at the local level. And we need to understand that we are, when I say we, meaning African Americans, are directly affected by all of this, no matter what our age group, no matter what our status is in terms of finance. We're all directly affected because we do have little boo-boo and our little cousin who is probably having difficulties, and we cannot separate from that. So we have to be on the same page in terms of being responsible for the policies to change.
All right, thank you. So I wanted to ask all of you, because we're getting close to finishing, and I wanted to give you all a chance to make some final remarks before we call in Renee Mahaffey Harris. So, you know, whoever wants to go first, if there's a message or some information you feel that we haven't covered that we really need to make sure we don't miss, please go right ahead.
So I'm going to say it very quickly. So if you need a counselor, a psychiatrist, or a coach who is down to earth and will give you good feedback, support, and practical skills to add to your recovery, UMADAOP is the place for you to come. We can be reached at 513-541-7099. We got you.
All right, thank you. That's great. Jamal, did you want to add something?
Sure. You know, just a couple quick things. I think ultimately we want to make sure that this disease goes away in our community, particularly first, and as well as all communities, you know, because it is a disease, it is an illness, and it can be cured. But unfortunately, with policies and services and structures and things that are in place, that we're not at the table to have an articulate conversation around positioning what our issues are, and we're often left out. You know, being able to have access to be able to share that perspective and not have that voice muted by people that look like us and people who don't look like us is important and critical. And being able to have an articulate way of saying, these are our challenges, here are our opportunities, and here's what we want and need to mitigate them is critically important. So as often as much as we can do that, I think that's critical for our success going forward. And then what I will also say is, you know, as we move forward as the Crossroads Center, we're really looking forward to serving the community in any way that we can, partnering with whomever we can, because we understand that this is a heavy lift and it is not something that ends when people leave our facility. So it's important that we partner. It's important that we hold other organizations and industries accountable for their role in getting rid of this disease, and we all own it, or else this will be something that will perpetuate over and over again. I think there's a huge opportunity for us to work better with the criminal justice system to ensure that those who have felonies or convictions that are connected to an abuse or an addiction get the right services so that the incarceration isn't the end all for people who look like us that are addicted to the disease. And we have to do better. You know, we have to hold ourselves accountable first, but then also hold those who are on the opposite side of this issue accountable as well. And if you need help or services, we too are available to you. I don't care where you go, as long as you go somewhere to get the care that you need. But if you want to come to the Crossroads Center, we are available. 513-475-5300 is our number, as well as our website is www.thecrossroadscenter.org. Thank you.
I appreciate that. And, you know, you made a really good point. That's something else we should talk about at another time, the whole thing about people with addictions being incarcerated. You know, that's not the proper place. We all know that. You know, they need treatment, they need help, not incarceration. And so that's, you know, that's a whole nother issue, you know, we should talk
about.
And
Jan, I would like to be on that call because we have something called Circle for Recovery. We are also involved in the incarceration of our clients, trying to make sure that individuals who are returning to the community, we have a program called Circle for Recovery that we provide that same kind of objective in terms of making sure they have the proper therapy and all of those issues with employment is taken care of. So, yes, we can talk about that another time.
You know, my friends who are listening, who are involved with Hamilton County Drug Court, I'm not forgetting there's a drug court. So I was just talking about, you know, the people who don't make it through there. Okay, just want to make sure you all know, there is a drug court. Okay.
And we do a lot of work with them as well, Jan. You know, Judge Russell and all of the Change Court and Mental Health Court judges over there. We have a great relationship with them in partnership, but it needs to be made stronger.
All right.
Absolutely.
That's good to know. Thank you. Dr. Burlew?
Yeah, I'll just close really quickly by saying, you know, I really appreciate being on this panel. And when we're thinking about our mental health and substance abuse, one thing that I want everyone to remember is that despite all of the atrocities that our community has gone through, we are a very resilient community. And we are still strong and moving forward. And one of the things that has helped with that resilience is our connection with one another. So in this time of physical distance, I want to encourage everyone to stay connected with friends and loved ones. And when you have friends and loved ones who are suffering from some of the things that we talked about today with regards to mental health and substance abuse, please spread the information about UMADAOP, about the Crossroads Center. And I know that Closing the Health Gap has even more references on their website that can help people. So I just want to encourage people to share the information today and to reach out to people, particular people who are having to quarantine in isolation, and make sure we keep that connectedness.
Thank you so much. And I'll echo what Nicole P. said here. She said, this is awesome information. It really is. Before I turn it over to Renee Mahaffey Harris, who's President and CEO of the Center for Closing the Health Gap, I just want to thank Leah Dennis-Ellsworth. So glad you got on the call. Jamahal Boyd, and also Dr. Randi Burlew. Thank you. You all have such great information, and you open our eyes to a lot of issues. So thank you so much. So attendees, thank you for listening in. Thank you for joining us, and we will be back next week. We're going to talk to our state reps and senators about some upcoming legislation and information that's going on in terms of showing that racism is a public health crisis. That's going to be our topic next week. So let me turn it over to Renee Mahaffey Harris.
Well, first of all, I want to again thank President Jamahal Boyd of Crossroads Center, Director Leah Dennis-Ellsworth, and Dr. Randi Burlew from Cincinnati Medical Association for joining in today's conversation. It is just the beginning. I heard each of you say very critical information about the fact that we must connect to each other. And just as you described what each of your organizations did, and I know we're running out of time, I encourage you, please send me the phone numbers, website, information, any specific programs that you have. Having come from a relationship that my husband was a substance abuser, and just knowing what you don't know and potentially what is the activation point of turning to it for addiction to present itself. So it's the why, and it is human and it is relational. And so the fact that we have these two incredible organizations in UMADAOP and Crossroads Center that are led by Black people, that are primarily people that are providing the services look like us, is so very critical. We don't necessarily get included in the conversation when it comes to substance abuse and opiates, which is a tragedy. And only each of us coming together, just as Councilmember Kearney shared about racism as a public health crisis. Well, we know that racism is structural and institutional. Therefore, the fact that we don't necessarily hear the data about how we are impacted by substance abuse and stress and all of those addictive behaviors that potentially evolve out of where we are in being Black in America, your organizations are critical. And so it is up to each of us to make sure that UMADAOP and Crossroads Center is at the tip of everyone's tongue, so that's what we need to do for each other. So that's what I leave with us in this conversation, is that we must do better to make sure that the organizations that are serving the needs that are destroying our lives and our families, we must make sure that we all know each other and that we elevate the very great work that is being done by both organizations. So I thank all of you for being here today. And I look forward to us continuing the conversation, continuing to elevate and ensure that we are at the table. And we don't have to be at the table. We're going to elevate our own issues, and therefore they will.
Right.
So thank you so much. I want to thank our partners, the African American Chamber of Commerce, Eric Kearney, President, the Urban League of Greater Cincinnati and Southwest Ohio, Eddie Cohen, President and CEO, the President and Vice President, President Robert Richardson, and Vice President Joel Mallory of the NAACP, and Dr. Roosevelt Walker with the Cincinnati Medical Association, of course, our Councilmember Jan-Michele Kearney, for being our moderator, and for all of you being a part of this conversation. We must continue to talk and elevate what each other is doing so that we can save ourselves. So thank you all, and you have a great rest of the weekend.
Thank you so much, Renee.
Thank you.
God bless everyone. Thank you. Take care.
Thank you.
Thank you.
Next week.